you hear me? Yeah? Good. Welcome to this, I think we start as you're coming there, good. Welcome to this exciting session about integrated healthcare. We have 3 speakers, 2 from Norway and 1 from the UK. So this will be very nice. First, myself, I'm Hilde Lyngstad, and I'm a moderator for this session, and then work for the Norwegian Directorate of eHealth. Bent Høie said yesterday that his word was collaboration. And I think that sums up what this session will be about. Integrated healthcare, often referred to as interprofessional healthcare, is an approach characterized by a high degree of collaboration and communication among health professionals. And this makes it unique because it's team members working together. And I think eHealth will enable this, and this is what we will hear about. And there's a lot of benefits that I'm also sure that we will hear about. So it's knowledge, experiences, and maybe some plans for the future. So first, we will have a Norwegian speaker, and it's Muri. He will talk about one citizen, one patient record, which is a big Norwegian project. And it's a project that the Norwegian Director of Health and Directorate of eHealth have made recommendation for. And hope that it shall be realized in some years. Muri is a project manager, and it's a consultant at Director of eHealth. And he has worked with the strategic analysis. And now we will hear more about the project. Please welcome.
Thank you. Thank you. I guess these are my 20 minutes feeling like a rock star. I can't see anyone, but I noticed that at least some people coming in. So what I will do now is to try to condensate approximately 1.5 years of work, doing what we in Norwegian call utredning av en innbygger en journal, which I will refer to as a strategic pre-study when I use the term. Obviously, this will be the highlights. Hopefully, I can clarify some misconceptions or misunderstandings. But I think most importantly is what is the status now and what is likely the way forward. So I guess I'm speaking to the congregation, meaning that these are the people already convinced about e-health and digitization, technology, etc. And probably the storyline could have been changed from enabling to driving. I think many of us experience today that it's not too much about enabling anymore. It's technology even driving the health system. What we obviously have based our work on is the strategies, the policies, the objectives of our politicians, and obviously the sector itself. For our work specifically, it's definitely about the integrated and coordinated care paths across enterprises and across geography. That's very much the essence. And obviously, patient quality, patient safety, patient-centered services, and increasingly also the objective of reducing variation. These have been, key objectives in our work. In addition, we have a sector that currently employs approximately 250,000 health personnel. And if you extrapolate the current numbers to 2030, there is a significant increase in the requirements for health personnel. That might be the need. I shouldn't say anything about that. but it's obvious that we need to make the sector and the health personnel productive. We have to provide them with good day-to-day working tools. Otherwise, the numbers of health personnel required will increase even more. So, sorry about this transition thing. I think most of you are aware of this one. This was the starting point of our work. And one conclusion that oftentimes have been neglected is that actually the first recommendation from our work is to focus on objective number 1. So what we did was to say that providing good tools and good systems for healthcare personnel, providing them with access to relevant information, indifferent of where health treatment has taken place, is the most important objective. I know some will disagree with me, but we saw that as the key critical component and the starting point for enabling services and reaching the objectives for number 2 and number 3. So in terms of what we have drafted out, in terms of what we have estimated, in terms of needed investments, we have focused on number 1, but obviously we will enable number 2 and number 3, but it's not part of the project. Solutions, systems, applications, vendors, plural or singular. I think that has been the most oftentimes discussed item. We, in our recommendation, refer to a core system. We focus our recommendation on creating an effective system for clinical documentation, process support, and patient administration. That's the core. We do not say anything about this being delivered only in one system or from one vendor. We acknowledge that this can definitely be delivered through several systems. However, what we have seen or what we experience is that the processes of clinical documentation and patient administrations are very interdependent tasks and work processes. So as you break these up with support from many systems, and these systems are not well integrated or interconnected, you get disruptions in the work process. And that is also a key observation from many of the reference visits that we have made, that if you break this up too much, the health personnel will experience this as loss of energy, loss of time. You have to go into several systems to find the relevant information, etc., etc. When we do our calculations based on current definitions, oftentimes referred to as EPJ-PAS or EHR and patient administration, this currently stands for approximately 20 to 25% of IT spending, approximately. Our guesstimate is that this number will significantly increase as other systems will expand. Technology, digital services, etc., will expand in the sector. We do not want the task of solving all of this, but we are clear that the core system is of core, and it needs to be a platform that can be integrated to all the other systems. As such, we oftentimes refer to this more like infrastructure than an application in itself. Going back to my point on enabling the other key objectives. So we would like to stop with fixing the core, whether it's one system or several systems from one or several vendors, we have not decided. And we see, even from the few months back that we did this work, the vendor market, the solution market is evolving. But the response to how this should be solved should not be with us. It should be from the market and the suppliers. So this is the very overall recommendation. You might call it generic and obviously very high level. It's difficult to govern on. But we were very happy with reaching such an ambitious objective with a very good participation of key people and key enterprises in the sector. So the municipalities and the specialist health services, patient and user organizations stand behind this recommendation on a high level here, obviously. So what happens now? Well, bullet number 1, which is the future target state, you might even call it a vision if you would like to, has been decided to be validated and maybe tried out in Midt-Norge. I won't call it Middle Norway because it sounds so strange. So Midt-Norge, including the specialist health services and the municipalities, etc. in Midt-Norge. They are currently running a procurement which has the ambition illustrated in bullet number 1. Bullet number 2, we saw very clearly that the needs were strongest among the municipalities. They were very clear that their current solutions do not meet current and future needs. I'm not saying that that's the fault of the solutions or the vendors, it's just a situation. They don't get fulfillment in their current solutions. And I would like to praise the municipalities for acknowledging that continuing on the current operating model, if you like, or delivery model, whereby 428 municipalities try to resolve this individually, is not the way going forward. So praise for the municipalities for thinking radical, if you like, and saying that we could actually be interested in having this provided as a national service or as a common solution for the municipalities. Currently, we are doing activities in 2 areas. 1, we have an instruction from the ministry to start planning the realization of one common national solution for the municipalities or for the primary health and care services. Secondly, we, as the directorate, but also other enterprises in the sector, have the order to support Helseplattformen. So as we speak, there are 40 people from municipalities, specialist health regions, and national bodies sitting down and going through the tender document that Helseplattformen will publish in approximately February. Giving national input to the tender document and trying to make sure that the needs that we describe, the requirements that we describe, are as close as possible to what we would have described if we have done it national or in another enterprise. So now there is a national collaboration on that. Secondly, there has been national representation of people in the governing boards of Helseplattformen. And we have agreed with Helseplattformen to collaborate on updating the tender document. As you know, it's a competitive dialogue and there will be several versions of the competitive document. And we have also decided or agreed that we will collaborate on what we call key subjects, where we see there is a national interest to try to harmonize or standardize. And these could be within different areas, but obviously standards, codes, terminology is a key. Regulation is a key. Prescriptions and medicine is another area. And we will set up a plan with Helseplattformen just before Christmas, where we outline how we should collaborate on harmonizing this on a national level. I initially said something about not concluding on whether this is one or several systems or this or that vendor. And that's also acknowledging the fact that the technology and the vendor landscape is moving. So trying to look ahead, there are many scenarios, at least for such a big ambition. Helseplattformen currently has the ambition of providing one solution on a regional level that is comparable to the national target state of one common system. It's too early to say whether this can be realized. In December, we will know which vendors do qualify. Springtime 2017, we will have the first tender responses. So we will have learning continuously in the process of Helseplattformen. The first learning we have, which I at least think is positive, is the joint process between GPs, municipalities, specialist health have displayed that there is a collective recognition of needs and requirements. We were fearing that priorities or requirements would be very different. The practice of municipalities and specialist health is obviously different. But so far, at least, they have agreed about many of the key requirements. And for those vendors that will receive the document, they will see that many of the needs areas and the requirements have been marked with common. It's a common objective for municipalities, but also for specialist health. Then we have, I don't know what color it is. It's not shades of gray, it's shades of green or something. So don't put too much into it. It's just displaying that we have 3 large specialist health regions that have a somewhat equivalent strategy for the core system of EHR and patient administration. And these are doing now some very important work in transitioning to the next generation of their solution strategy. This journey, going on approximately until maybe 2020 or 2022, will give us key lessons in terms of the way forward. This has started directly and indirectly. There is a close connection between what happens in Midt-Norge and what will happen on a national level, i.e. the process I just explained about the people being involved in the tendering documents. However, there is a lot of work left to plan this and to go into the real details in terms of the requirements in the municipalities. So what this will look like in a year or 2, I don't know. It's a bit evolutionary. In 2017, we will continue the cooperation with Helseplattformen, and we will continue the planning of the national realization of one common solution for the municipalities. In that work, the other 3 specialist health regions are key in making good evaluations and strategic decisions. More in practical terms, realizing the blue solution is something that we haven't done before, obviously. And it requires new thinking with regard to how should we finance this? How should we operate it from an IT point of view, but also from a clinical point of view? How should we break down what is very big and very complex? How many projects should we run in parallel? Where should we start? These are key questions that we need to address in 2017. In addition, we would like to address what is here referred to as sourcing and contracting. We know that we want to use the market extensively, but in what way we will use the market is still unclear. Also here, Helseplattformen will give us some input, and also the large tendering processes and the experiences from both the municipalities and the other specialist health regions will be key input when we decide on future sourcing and contracting. So these are key activities in 2017. Okay, is the question time or is no? Yeah, any questions? I think I have 2 minutes left or something like that. It can't be so clear.
Any questions?
Okay.
Well, there is long-term plans.
Either loss of interest or everything clear. Yeah.
But do you see any main challenges?
Yeah, I think main challenges, currently at least, are the ones I just mentioned. So this ambition and these solutions, they challenge the current finance model, governance model, organizational structures, having things delivered as a service from someone else compared to having full control yourself is a challenge both culturally and structurally. And so these are the main items at the moment. Yeah.
Questions?
No.
No hands? No?
Thank you.
Thank you. And you'll have a small gift from me.
Thank you. Thank you.
So our next speaker, he is from the UK, from Wirral, and I had to look it up. It's a peninsula in north-west of England, or UK, and it's very close to Liverpool. John Develing, and he is NHS Wirral Clinical Commissioning Group he's working for. He began his NHS career in 1980 and has a clinical background in both general and psychiatric nursing at hospitals. He was appointed Regional Director of Operations and Delivery for NHS England North in 2012 and has since started working at NHS Wirral Clinical Commissioning Group as Chief Officer at the beginning of May 2015. He will describe what the Wirral health system looks like, its challenges and strategy for new models of care, and its implications for leadership with healthcare. I think we will learn more about how solutions help healthcare and society every day. So please welcome John.
Good afternoon, everybody. Let's start with something interactive. So Wirral is a really difficult place or a difficult name to say. So would you like to practice with me? Okay. So if I say Wirral, because it's quite a difficult word to get your tongue around, and if you just repeat back, just encourages me as well. So as loud as you possibly can. Wirral. Wirral. Excellent. Because lots of people say, how on earth do you pronounce this place? Because it's full of vowels and it's full of consonants, but Wirral it is. And I'm very proud to and feel very privileged to come and share with you some of the work that we're doing. It's not necessarily the right thing for every system, but it's something that we're trying to tackle at the moment. And I hope my English is not too difficult to understand because whilst I'm born and bred on Wirral, I'm not quite Scouse, but if you heard somebody speak Scouse, it wouldn't sound quite like this, but I appreciate it might sound very Scouse. And I'll travel through the presentation quite quickly because I think there's some, what I'd like to do in the first half of the presentation, talk about Wirral, the challenges we've got, and then some of the solutions. And I'll try and bring out some practical examples of where we're starting to see some traction. The first thing to say is we've defined ourselves as a system. So the isolative policies that we've had in the NHS in England in the past of foundation trusts, payment by results, tariff-based systems have only forced people to start to work in isolation. And so we've defined ourselves under a single brand of Healthy Wirral. So you won't go into a hospital and see it with the hospital name. It's called Healthy Wirral. You won't go into social care and social services and see adult or children's social care. It's Healthy Wirral. So we're trying to work in a system approach, in a collaborative approach, and an integrated approach. And when you say that to the public say, well, what do you mean? Isn't that what you do anyway? Well, sadly, no, it isn't. And so I'm speaking today as the Chief Executive Sponsor for the programme. So I'm therefore speaking on behalf of all organisations, and the logos you can see are above you there. So where is Wirral? Well, it's in the northwest of England. It's a peninsula. It's surrounded on three sides by water. We have the River Dee on one side. We have the Irish Sea on the north side. And we have the River Mersey on the west side. So we face a World Heritage Centre, and you can see a picture there of the three queens, the three flagships of the Cunard Line as they sailed in 2 years ago. And I was reflecting on what they did that day was to sail three of the biggest cruise liners in the world down the River Mersey in full flood. That's a 32-metre tide, turn 180 degrees stern to bow, and then come alongside. Now, I've got a powerboat license, and I couldn't do that. And that took 5 years in the planning, never ever done, and on that single day executed it perfectly. How many of us have got a plan that we've been working on for the last 5 years and executed it perfectly in one go? So a great testament to everything that I'm not very good at took place on that day. So a little bit of information about Wirral. This is the peninsula. It's 15 miles by 9 miles. We have areas of very great deprivation, and we have areas of quite good riches. If you live on the D side of the Wirral, which is on the left-hand side, your property could be worth anywhere between £1 million and £50 million. And on the right-hand side, on the Mersey side, your property is more likely to be worth about £50,000. We have the best and worst health in Wirral. We have areas of high deprivation, poor housing, high unemployment, poor life choices, and poor life expectancy. And if Wirral was 100 people, if it was a village of 100 people, then 68 would be obese, 32 would be live in deprived areas, 20 would smoke, but in the deprived areas that number goes up, and 15 would live alone, and again in the deprived areas a lot more people live in social isolation alone. So something about a breakdown in communities is taking place there. If I look at the difference between life expectancy of the best and worst wards, their localities within Wirral, then you can expect to live 10 years more in those areas of wealth compared to those areas of deprivation. So therefore, the learning that I think we're trying to get out of the projects that we're doing, I think is significant to our country. That's why I'm so excited about it. I think we've got a story to tell. We're a microcosm of inequality, so let's see if we can tear the rule book up and try and do something different about it. Life expectancy for females and males is worse than the national average. And if you look at our population compared to the national average of over 65s, we are significantly higher. And we expect our over 85 population to double over the next 20 years. So by any stretch of the imagination, it's a system under challenge. It's a system that's saying what's worked for us in the past doesn't work for us now, and it's not sustainable going forward into the future. And that narrative is landed with all partners. We all recognise where we are. And the reality is, in terms of where we are, if we do nothing, we'll have a £170 million problem in 5 years' time, which is the graph on the right-hand side. That is income versus expenditure in terms of our thirst for health service being delivered in the way that they're being delivered. So demand and supply, aging population, case for change, financial case for change. We sat down as partners and said, what are we going to do about this? Because let's not kid ourselves. Every year we've said, what are we going to do about it? And it seemed to me that the only plan that we had was this one. Let's hope for a miracle. And it seemed to me that the conversations that were isolated to secondary care, primary care, community care and social care was moving money around the system, but it was only taking it out of one pocket and putting it in another pocket somewhere else. And the sooner we work as a system and collaborate, the better. So this miracle is not going to happen. So it absolutely needs vision, it needs leadership, and it needs clarity about what the issues are. And so we did develop and have developed this plan. Based on some of the learning that we've taken from other parts of the world. Integration can mean different things to different people. I know integration means different things for IT. Integration means, for me, seamless care delivered to the patient. I don't care which organisation delivers it, but it must be seamless. The patient doesn't care who delivers it as long as it's delivered in a seamless way. So integration means the creation of single therapy services across Wirral, not a therapy service in the community, a therapy service in primary care, and a therapy service in the hospital. Why haven't we got one therapy service? It's much better for staff. It's much better for patients. Staff are much more dynamic and much more fluid, able to go around the system. Great career development opportunities, great experience. So that's a kind of integration I'm talking about. But we absolutely know, and we know from the work that they've done on Intermountain in particular, that the payment by results system that we've operated in England is replicated in the States, where people are chasing income for organisational benefit. And that means we're starting to do things for patients that we don't need to do because our priorities get mixed up. And Intermountain, and these on the right-hand side there, looked at each dollar that they spent, and they discovered that 20% of the costs were inappropriate because they were chasing income. They discovered that 10% of costs were unavoidable if care had been provided in a different way, and more importantly, 22% of costs, 22 cents in the dollar, was being wasted because of clinical variation in practice. So standardization, do enough but don't do too much, and look at opportunities to divert care away. So only 39 cents or so in the dollar was spent on adding value to patient care. And there's a great deal of learning that we've taken from that to put into our plan. So what we want to do was to target our interventions in the most effective way, using technology, and we've been operating a digital, and I love the word driving. It's absolutely driving technology to meet our demands and our expectations. So it's not a technology-enabled solution. We're saying to technology, you ought to be providing me with the answers to some of these solutions. So really looking to use technology to drive our interventions, to target who are the people who need our care. What sort of care do they really need? Because it's not what we're offering them now, quite frankly. So this is what we developed after a period of about 12 months' time. We had a conversation about trying to look at the wider determinants of ill health in a program called Better Health. We're looking at housing, we're looking at employment, we're looking at job opportunities, we're looking at green spaces, we're looking at depression, we're looking at things that enable people to go about their lives in a different way. We're looking at better care, particularly looking at mental health, end-of-life care and urgent care because they're our greatest challenges. And we're looking at better value. So better health, better care and better value as the principal language that's common across our system. There's a chief executive lead for each segment of the plan, but that's the only plan that we have. Let's not have multiple plans. Every year there's a new plan. This is the only plan that we're all working to. And this is the model of care that we're trying to develop, putting patients in the very center of the care. and having services around them. It's called the health and wellbeing model, and it's written up in many countries that I can see, and people go, yes, yes, we know about that. But very often, I don't see this is how services are being delivered. This is not what we deliver now. And putting patients at the very centre of care, asking them what they want, and what really matters to them is the first stage in population health. It's not the services we think we'd like to give them, and that's what our acute model is based upon. It's about saying, what care do you need, where do you need it, and then designing those services in a different way. This is typically a risk stratification triangle, which you're probably familiar with, but the population health platform that we're developing it has enabled us to identify and know the top 5% of patients who have comorbidity of disease, who are living an older life in a much more problematic way. And we've created integrated community teams, social workers, GPs, community psychiatric nurses, school nurses, district nurses, all working in a team, regardless of organisation, but allowing them to manage that top triangle of patients. Now that's 16,000 people for us, and we've only got 400 people within this program at the moment. But our ambition would be to roll this out to that 16,000. That will help us deal with the pressures that we've got in the system now. But if we don't look forward, as it were, to the pressures that are building, those rising risk of patients, all of which are in this room today, I assume you all know your blood pressure. I assume you all monitor it on a daily basis through some app. I assume you all know how far you walk or drink or eat. Your GP doesn't, but you do. So these are the rising risk of patients, the risk to us in the future. That's where we've got to get into, and that's where we're using the approach of trying to get real-time data on people like ourselves in order to inform the future way we plan services. At the moment, we've created some registries on diabetes for adults and children, and we've created a registry for respiratory care on adults and children. And that's enabling us to identify where those people who are most at risk of diabetes and respiratory disease in the future are, down to the streets and the postcodes. And when I look at how we deliver care to those people, we don't. So what advice are we going to give to those people? How do we deploy our resources around those needs in a different way? So what we're doing is we're looking at trying to do that in a non-traditional way. So this is where it maps back to our strategy. So in terms of the better health strategy, we're looking at how do we create better jobs, better high streets that don't have lots of fast food retail outlets and betting shops, etc. We're creating health and well-being shops. And what we're going to do, and what we're doing, is we're filling those shops, not necessarily with community nurses or GPs, but we're getting the public on board to say, can you become a Wirral champion and be based in those shops? Because I'm running a marketing campaign with no money. It's a social movement that's being created, and we're doing it with the local metropolitan college, who's got 16,000 students who are saying, we do business, we do design, we're doing nursing degrees, we're doing all sorts of things. We can help you. So we've engaged with the colleges who have now become 16,000 champions for Healthy Wirral. It's become a social movement as such. So I'm running an advertising campaign on a budget of 0 and having much more effect than I could ever have with leaflet drops. That gives you some idea of the kind of stratification that we've gone about. And we're asking this question on the right-hand side. Typically, we'll go to your GP or you go to a hospital, and the first question you're asked is, what's the matter with you today? The conversation's got to be, what matters to you? Not what's the matter with you, but what matters to you. Because unless we design care around the patient, we'll design it in a different way. Don't be afraid to have that conversation. Because when we had that conversation, people said to us, but patients will want so much you can't afford it. Absolutely not the case, and quite the contrary. We have patients in hospital, and we do an assessment before they go home for discharge, and we design a care package. They go home, they go into their home, and the care package then breaks down because it didn't meet their needs. because it didn't meet their needs in their home, because we didn't ask them, what do you need at home? We assess them in the hospital. A patient who presents in A&E with a respiratory disease is known to primary care and has been known to primary care for years, and they've managed that. They go to A&E, and A&E says, we need to admit this patient. But they spoke to the GP said, but they're always like that. I'm managing that, okay. You don't need to admit them. And so we've got disincentives, discommunication within the whole system. And that's why we're using digitally enabled technologies in order to begin to break down some of those barriers and have the conversations. These are the conversations we've had over a whole series of engagements, and we've developed these models. These are 3 stories that we're using with patient groups, with diabetes, with respiratory care, saying, if you were Mike, what do you think you'd need? If you were Tom, what do you think you would need? Not Tom, Jeff. What do you think Jeff needs? And you could have a look at these and say, well, we think he needs to do this, that, and the other. Are those available? So we've had lots of engagement with patients. And the model of care that we have for diabetes is this one. I won't go into any great detail because of time, but this is our current diabetic offer. And that diabetic offer costs us, in the right-hand corner here, around about £44 million a year. This is what the patients told us they really want. They want to have a one-stop shop. They want to have a team of people who can manage their care. They want a responsive service. They want to be able to use telemedicine. I don't want to sit for hours in an outpatient department for a consultant who I don't see, who's running 2 hours late and take half a morning up. That's an old model of care. Why can't I FaceTime him? Why can't I use telemedicine? Why can't I? So this is where digital technology comes in providing that data. And why can't I own the data? So if I go to my GP, for example, and this is a real example, I go to my GP, I've been monitoring my blood pressure for the last 6 months, every single day. I go to my GP and say, I'm concerned about my blood pressure. What are they going to do? I'm going to take your blood pressure. And the first thing to do is they take the blood pressure, because it's almost as if the BP belongs to the GP, not to the patient. So we're having conversations about how do we, because we are the problem, let's be clear, clinicians and people like myself, and I'm a clinician by background, we are part of the problem. We have to think about this in a completely different way, because this is what patients are telling us. And these registries that we developed, we estimate the first registry that we're rolling out to save us £1.5 million this year. But if you cumulatively put that together with the other registries, it starts to eat into that £170 million problem that I've got. It won't do it all, because there are lots of other things we need to be doing, but it's a great improvement. So my main message today is about population health is, do you really know who those people are who need our care? We were finding that there were patients who were coming in and out of hospital recurrently. We had our intermediate care teams managing high-risk patients, but they weren't the same patient. So we thought we were managing the right patients, but we didn't. And we didn't know that until we joined up the community-based data and the hospital-based data and the primary care-based data. Everyone was managing high-risk patients, but we had a different definition. So know your population, engage with the population, manage and deploy your resources as appropriate. And those resources don't always need to be the traditional method of deploying resources. There are other people out there, the voluntary sector in particular, who can help us. I think that will help us reduce variation. I think it takes duplication out of the system. I think it takes out waste out of the system. And it goes a long way to actually meeting the needs of our population. It is a platform for a different relationship. It's a platform for shared accountability. Some people call it accountable care. I call it shared accountability, because it's no good having one part of the system bust while another part of the system isn't. And here's some of that progress. So I'll summarize with 2 things. This is what I think a good system looks like. A good system has shared care records. That's transferable data right across the pathway now, and we've heard a little bit about that this morning. A good system also, though, has real-time or as near real-time data as possible. A good system has clinical leadership, and the only one I could find was House. Is that okay? But you also need to work within a brand, and we've created the Healthy Wirral brand as something that everyone can visualize and work to. Do enough for people, but don't do too much. I find that a hard conversation, but that's the medical director of Intermountain Healthcare was telling us that. Do enough, but don't do too much. Look at patient-centered care as the platform for designing services around rather than the offer that we give people at the moment. And look at culture. So we're starting this process with our staff, and we're talking to staff about changing the way we work. I can't ask people to work harder. And at the end of the day, it comes down to a choice about personal accountability, because to do this does require change. And a lot of people will say to me, but we can't do change because of legislation. We can't do change because of politicians. We can't do change because these are the rules. And what I'm saying is rip the rule book up, folks. There are things you can do, and if you look at what you can do most of this within your frameworks now. And the choice is that we just sit there and let this carry on, or we start to take personal accountability and say, actually, we can do something about it. And this video, as a closing video, hopefully just serves to prove that point. This is a challenge to me as well as everybody in the room. Don't think it's going to show.
Whoa, that's not good.
Okay.
Oh, I don't need this.
Can we stop the video?
Late.
Somebody will come.
Oh,
Anybody
video.
out there?
Do you have a phone?
No. Sorry.
The start of the video didn't show, so let me catch up. There's two people on an escalator, and the escalator's going up, and the escalator stops, and the story continues.
Whoa, that's not good.
Oh, I don't need this. I'm already late.
Somebody will come. Anybody out there?
Do you have a phone?
No. Sorry. Somebody! Hello? There are two people stuck on an escalator and we need help. Now, would somebody please do something? I don't believe this. You gotta be kidding me.
I'm gonna cry.
Well, there's not enough left to do, is there?
Does that resonate? Thank you very much.
Very, very interesting. Questions? Oh, come on.
I appreciate it's really difficult to take questions
There.
in a place, but I'm happy to take questions at the end, if that's easier.
So, thank you. The issue of merging health and social services is not on the agenda in Norway. I'd like to hear your thoughts about why you've done this and some of the challenges.
Okay, so we're not merging. So language is really important, isn't it? Particularly in political places whereby our social care system is means tested, and I have a health budget which is a capitation allocation. And so there's a lot of suspicion that if you were to bring those two budgets together, one would cross-subsidize each other, which is why we go back to the value-based principles that we started with at the very start. And yes, resource is an issue in that conversation, but actually, isn't it about people? Isn't it about where people are and what they're experiencing? And so how do we create a pooled resource in order to do that? So we have something called the Better Care Fund in England, which is an amount of money that both health and social care have to pool in order to deliver some of those services. And I see that that is the future. I think that the commissioning of social care and the commissioning of healthcare have to be done together, because if they're not, then the whole pathways of things like urgent care fall apart. And quite truthfully, from my perspective, I can't talk about the politics here, from my perspective, the sooner we begin to integrate those commissioning functions, the better. And that's what we're doing on Wirral. So by April next year, we will have a single commissioner, and those budgets will be realigned. Of course, there are assurances on the social care budget that need to report to we have a cabinet for the local authority, that'll have to be done. But actually the commissioning of the services are together. If you let the financial thing determine what you need to do, I think we've lost the plot. But actually, shouldn't we be commissioning adult care, domiciliary care, and community care together? The two are intrinsically linked. So we can commission together, even if we have to do some sort of financial risk management, that's fine. You know, people much far cleverer than I am can come up with that answer. But we absolutely should be commissioning together.
Ja, Jon Torgeir.
Thank you for a very nice presentation. I wonder, throughout the world there are ongoing projects to try to establish so-called accountable care organization. And the main point for me is to ask you about, in these ACOs, they share the costs and they share the results. They are together to the total budget and the results of the collaboration and the common effort to achieve common goals. You have hospital trusts, you have community trust, you have mental trust. How do you have this corporation being accountable in an economical sense as well?
Yeah.
Sharing costs, sharing results.
Yeah, absolutely. So the business model we have of payment by results and allocations to CCGs or the commissioners on a capitated basis don't go hand in hand, because you'll have costs that are incurring here and they're not costs within the commissioning budget. And so the thing that is driving costs for us is demand and growth. And so I call myself a bureaucrat. I'd like to think I'm a little bit more than that. But if I was to stand back, I don't refer a patient. I don't manage a patient. I don't make a clinical decision about the admission of that patient or the discharge of that patient. That's about clinical decision making. It's about shared accountability, and that's the driver for accountable care, not the organizations. So I'm a real advocate for not using the word accountable care organizations, because it gets in the way of collaboration. What it should be is shared accountability through a single governance process and a partnership approach. I'd much rather they were called accountable care partnerships than organizations, because organizations mean so much to different people. It might mean, oh, well, the acute sector saying, well, we're going to run this, or the community saying, well, we're going to run this. Well, the answer is none of you are going to run it. Okay? We need a governance arrangement across our system that will make those decisions for us. But what we don't want to lose is the clinical input to commissioning and managing care in that appropriate way across the pathway. So I don't like ACOs. I do like accountable care partnerships, but the essence of it is shared accountability. And I think the King's Fund in England have done a really good piece of work on accountable care, if you'd like to read that. It doesn't talk about the shape or the form, but it does talk about 14 principles that you can find in a good accountable care system. And if you start there, then the form will come out. It's a bit like form follows function, you know. So if you start with the principles, then I think that's a way to do it. But it could mean, and it has the potential to, if that partnership decides to drive out organizational form at some stage. So I do think that, you know, I don't want to hide behind the question, because I do think that we'll have fewer organizations in the future. And I think we have to, because the public demand that we spend their money in the most appropriate way. And so to sustain management costs, and I'm one of those, to sustain management costs at our current level is not acceptable when we're looking at redesigning services to such a great extent. So it's shared accountability is the message.
Then we have to go on in the program. Thank you very much. Very interesting. I think we need to talk more to you. And you will also have a glass apple from us. Thank you. Then Nina Vind Unstein will come to the scene. She is a product manager for helsenorge.no in the direction of e-health. She's a colleague of me. She has previously worked as a strategy and supply chain consultant for a range of private and public companies. She has also worked for the Department of Health in England and the HSE in Ireland. She will describe how we, through helsenorge.no, the one portal for digital health services in Norway, are enabling digital services and will enable healthcare services. So, welcome, Nina.
Tack. Okay. Just to start off, what I'm going to talk about has something to do with the previous talk, which was very, very inspiring. Helse Norge is a portal where we find the it's kind of the patient-facing part of the health system, digital health system, and it's created in partnership with all of the organizations that contribute to delivering the healthcare to patients. It's even governed by a body that collects all of these organizations together, but they haven't synchronized, so we haven't done the sort of organizational changes that you were talking about, but we've these are the bodies that are driving what's happening with the national portal. It's a place where you find quality information about healthcare, about the sector, about where you can access healthcare, and about how to manage your own health. And it also has a range of patient self-services. Now, in your life, you are in all these different stages. So sometimes you're healthy and well, and you need information to stay healthy and to make the right decisions about your life. Other times you'll fall ill and you need health care, you need treatment, and you need to receive this in an effective and efficient manner, both from the healthcare provider perspective, but also from the patient perspective. And you may also be living with chronic diseases, and in those cases you need help to live well. So the objective is to have a online digital health services that meet you and are relevant for you and useful for you in all of these situations. And we've started to build this solution, and we're starting to gather the healthcare that you need in this solution. And as a patient, what happens when you are in these situations is that you are faced with a lot of different organizations to support you. It can be difficult to navigate in these different bodies that are helping you. It's a lot of coordination. There's a lot of information that you have to get from all these different places. And it can be very difficult, especially if you are ill and find life in normal a bit challenging. So the objective is to have this one doorway. What you find if you open the door is basically a set of services. Here on the left side, what you see are services that help you administer and your calendar, your health calendar. It has your appointments. You can see your health data. You can see the journal data. That's what's in the EPJ that the doctor has. And on the right side are services to help you get the right treatment, services to help you maintain a good, healthy lifestyle, services that you can use in combination with your follow-up at the doctors. And at the bottom, there are some services to help you engage your carers and take part in your digital health services and decide how you want to basically engage and use digital services altogether. So Helse Norge is available across all different devices. And if you log on to the services, you find your own data and your own personalized services. What you see here, and I'll give you just some few examples, are services where, for instance, in the message center, you'll find messages from your GP, from your secondary care, your hospital. You'll find messages from your cancer coordinator. So basically, it should give you a holistic overview of your services. You'll also find services such as book my patient travel, look at how much money I've spent on health and what kind of rights I have, and look at my prescriptions. If we look at the GP end of the services, you'll find opportunities to have consultations with your GP, to book an appointment. And what happens now is that it's connected, that goes into the EPJ of the GP, and it basically opens the EPJ and looks at what are the available slots in the calendar of your GP. Or you can decide that you need to look at your prescriptions. And what happens now is that it looks into the national e-prescriptions database, and it shows you what are the status of the different prescriptions that you have. So you basically have one entry to a lot of different systems at the back. What must be said is that we are in a process of rolling out services. So these services, luckily my GP is one of the GPs that have services on Helse Norge, so I've been able to actually use it in a good way. But it's being rolled out, so GPs are making use of the services, and we hope next year maybe 70% of all GPs will be available through Helse Norge. 2 health regions show journal information and appointments, hospital appointments, and allow you to send a message regarding your appointment. Soon it should also be Helse Midt and Helse Sør-Øst. So it's not kind of reached its potential yet. At the same time, we see things happening in the world that are very exciting. So the image I show now is from a television show where you see some doctors and some people that are coming off the streets. And they are faced with a challenge, which is to diagnose different they get some information about someone who comes into the room, and they're asked to tell what's wrong with this person. Now the doctors, they of course have a lot of education and experience and are very clever. The people on the other side of the table, they have internet. So it's basically internet versus education that you have. And this is a proof of showing how patient and carer roles are changing. Patients are moving from being someone who passively receive health to someone who actually can engage in their own healthcare and well-being in a whole different way than before. It's a challenge to the healthcare system, but it's also a huge, huge opportunity. What we know today is that a lot of the treatment that are given and provided is not working. It's not because these doctors aren't brilliant, because they are actually brilliant, but it's because they don't have the sufficient tools to be able to make the right diagnosis and the right decisions about treatment. They don't know what's happened in the other places that the patients have been before. They are limited to what the patient is able to tell in the consultation. So when the patient comes into the conversation and you ask, so how do you do and what's your condition, they will recount something, but it's often very, very unstructured and very limited what you can tell. So these days at the conference have shown that there are a lot of tools available that can help you in this conversation. You can have ways of providing measurements between the meeting points. You can have ways of making notes. You can have forms that you fill in to actually describe your symptoms in a much more structured way than what is possible if you don't have any guidance to do it. And this is what we are thinking is something that we want to help and be part of. it's going to be a big benefit for the clinicians because they'll have much better tools to do their job well. And if you imagine that they get a very structured story from the patient about what's actually wrong, they could even dip this structured patient story into this big data pond and pull out something that would actually reflect that what's worked on patients with these similar conditions, what did they do, and what's actually a good treatment option for them. And this is part of what the first talk will help support, is that if everyone has a core system that actually works and handles data in a much better way than today, this process of actually using health knowledge in a better way will be much easier than what it is today. But also from today, we know that there are really good examples of systems that you can use immediately from next year to start working in this way, and it's a very useful thing to start practicing on. So what we have done so far with Helse Norge is very much about building this foundation, building some services that are there today, enabling the connection between you and the clinician for dialogue, simple dialogue, looking at appointments, booking appointments, and seeing your patient journals and so on. And when I say we, I mean we as the health sector, because there are many people in this room that has been working very hard from all different organizations in order to realize the services that we have. People from the health regions, people, GPs, the system providers, NHN. There are lots of organizations that make actually this work. So we're not quite ready yet. I mean, we haven't completed this job of making the basic services, but there are lots of things there. What is really exciting is the possibility of enabling a lot of these new services for treatment, for learning, for decision support, for structured gathering of data and monitoring through Helse Norge. So if we have a patient as an example here with his diabetes application and some other measuring devices, he should be able to communicate with his GP or with the hospital in order to invite them to be part of this treatment. And on how to support this development, this is not about Helse Norge building a lot of interesting and funny new health applications. It's about allowing all the useful value-adding applications that clinicians have worked very hard to develop, that have a lot of insight into them, into the system. And I was at the talk yesterday talking about heavyweight IT and lightweight IT. So they shouldn't all need to be, we should allow them to be lightweight IT applications. So it should be possible to get entry into the digital healthcare system without having all the fundamentals that you need to kind of be there. You shouldn't need to integrate with every APJ. You shouldn't need to integrate with all of the registers. There should be a kind of platform that you can plug into and then have your applications work much more easily than if everyone has to sort out the whole infrastructure. It requires something that we still need to do. It requires work on standardization. It's very important. It requires that this will work seamlessly in the clinicians' system and working processes that they have today. We do need to do something on qualification, quality assessment of the different applications. Not because we want to limit it, but because we should make it easy for clinicians to make use of them. So it's much easier for a GP to start using something if someone has said, hey, we've already looked on this for you. It's actually safe to use. Well, maybe we should be a bit flexible. So maybe we should say it's safe. We haven't really the full evidence that it's working miracles, but it seems sensible and it's safe to use. So you have to find out about how to make it how to excel the speed of making new useful technologies available. We also need to help, and this is part of the plug. It's kind of, there are limitations today about this rules and regulations, especially on how to manage sensitive health data. So it should be possible to engage in this digital health system without and storing data and also having ways of storing data that is safe and secure. It should be accessible for patients and clinicians. So you have an app store today that has a lot of apps in it. It's very, very accessible, but it's pretty hard to navigate. So we should help promote some of these things that we think this is very useful. Try this in a way that the clinician should be able to refer you to it. You should find it. It can pop up as a message. See, here's something really important for you. Try this out. You should try it out, and then it sends a message back to your clinician saying, look, here's the result. So as an integrated part of care. And it needs to work across organizational boundaries, because e-health isn't, it can change some of the organizations and who provides what healthcare is also a bit flexible. Then also we need to broaden the reach of the current existing healthcare basic services that we have. So you should be able to enter into a system where all the different healthcare providers are there. So that should also be happening. So every day we create the future healthcare services. We are building it on today's infrastructure. What Are was talking about is that there are going to be significant improvements to this infrastructure, which is going to enable even better healthcare system services to be able to be provided. What we want is that you look into what you see on helsenorge.no, the services you find there. And you can also check the information that's in your own summary care record that you'll also find there, and you can even edit it. So if there's something that you want A&E to know if you fall ill, you should make sure that it's there. And we are working on the strategic direction for this portal together with the sector and together with the users. And if you have advice, if you have input, we very much want to know, because this is really the digital healthcare services. So it's important that it actually fits the purpose. So please make contact. I think that's all. And then there's questions, if there's anyone.
There. Oh. I get some exercise. Better health.
Thank you for an excellent speak and very good promotion for your app. I just downloaded it and became a user. That was very interesting. My question is, I was looking into my GP, and he's using Patient Sky, which is another system. So how are you thinking this different system is going to live alongside, or are they competing, or what's your thought about that?
I think there are going to be parallel systems. So there are going to be, in some areas, you'll have your provider, different providers will have systems that fulfill some of the same tasks that you also can fulfill in Helse Norge. And that's fine, and that's a good thing, because they can add, they can maybe, we say we have the basic services, different providers can have different value-added services, and they can actually move in a different speed. So that's I think is important that that you can have several different systems that solve some of the same tasks. I think a very big opportunity is these kind of value-added services, is where you actually have online services for mental health, or online services for diabetes follow-ups and so on. Those are the ones that I think is most important to be able to integrate into and enable as part of this whole digital healthcare system. So I think there will be a multitude, but I think there should be some basics that you can find one place across providers to make it easier. Hope that answered it.
We have time for one more question. No? For one of the other speakers, Are and John? Okay, then we say thank you,
Thank
Nina.
you.
Very good. And then it's time for a break. Half an hour, I think it is.